Welcome to Practical AI in Healthcare, the podcast that cuts through the noise to spotlight real-world solutions delivering real-world value. From patient care to clinical research, from life sciences to patient engagement, we focus on what truly matters in healthcare today. No hype, no theory, just practical insights where AI is making a true impact. Dr. Stephen Lapkoff and Dr. Leanne Rosenblit are your hosts as we explore what's real and moving the needle in this exciting new domain. Welcome aboard and let's get to it. As many of our listeners know, Leon and I work very closely with the DCI Network, a division of clinical informatics at Beth Israel Deaconess Medical Center in Boston. This June, the network is hosting Patient Powered Digital Health 2026. The conference will bring together patients, innovators, industry leaders, healthcare providers, and policymakers to shape the next generation of real-world, patient-centered solutions. The meeting will run from June 22nd to the 24th in Boston at Harvard Medical School. We've arranged for our listeners to get a discount on registration to the meeting. If you register now before June 15th and use promo code PracticalAIJune, no spaces, you'll receive 30% off your registration fee. You can learn more at dcinetwork.org/patients2026. In addition, we're always looking for sponsors. If you or your company are interested in becoming a sponsor, please reach out to admin@dcinetwork.org. See you in Boston. Hello, and welcome to this week's edition of Practical AI in Healthcare. My name is Dr. Stephen Lapkoff, and I'm here as I am every week with my colleague, Dr. Leanne Rosenblit. How's it going, Leon?
Oh, I've been better, Steve. I'm dealing with some serious nerve pain and over some meds, so I might be extra wacky today. It's going to be a fun episode.
This week, we're going to be engaging in a conversation which we haven't done on the podcast yet. We're going to be talking to a representative of the federal government. One of my former colleagues from my work at AMIA happens to be a gentleman named Jeff Smith. Jeff and I worked together on a number of initiatives over the years, and he is now on the staff at the Office of the National Coordinator in Washington, formerly known as ASTP. And Jeff has very kindly agreed to be interviewed for the podcast. And we'll ask him about his background in just a second. But Jeff, welcome to the podcast.
Thank you, Stephen. Thank you, Leon. Good to be here. Happy to make the cast or the pod. Do we call it the pod or the cast or both?
We even put them together like podcast. That's
okay.
I've heard. Yeah. But I like where you're going with this. I think we can play.
So, Jeff, our first question that we typically ask our guests is basically tell us your background story. Tell us how you got your superhero cape. How'd you end up at ASTP from AMIA? And what's that story?
So, I'm a meaningful use baby, like so many of us in the health IT space, especially of a certain age. I really cut my teeth on health IT policy back in 2010. And right around that time, there was about $34 to $37 billion, depending on who you ask, freshly minted to help incentivize the adoption of electronic health records. Congress, in its wisdom, decided they didn't want to just have a grant program. They didn't want to just put a bunch of money out there for people to buy things. They wanted to make sure that hospitals and physicians could demonstrate the meaningful use of electronic health records. And that kicked off a years-long and what's turned out to be kind of a decades-long process to try and both establish consistent standards for electronic health records, as well as develop policy to incentivize the adoption of those standardized electronic health records. And so that was 2010. I was actually kind of the second policy hire at the College of Healthcare Information Management Executives, otherwise known as CHIME. And you can always tell who worked at CHIME because they can rattle that off at the top of their head. And this is, of course, an association of hospital and health system chief information officers and other kind of senior executives within the health IT space on the provider side. And this was really this was a formative time for me, who has a political science background, has a public policy master's, but really kind of being able to work with strategic thinkers like CIOs and the CHIME board in a way that intersected with public policy and health IT was really very formative. At the time, the organization was, of course, very supportive of the funds that were newly made available. And we were able to fashion a relationship with both ONC and the Centers for Medicare and Medicaid Services to help them think through what ultimately we agreed were good things, but maybe we need to think about a different staging or cadence of requirements or a different set of functionalities and tools that CIOs knew their physicians and clinicians needed. So that was, so that was kind of the first 5 years of my career. And then, of course, I went to AMIA and was hired on there as the vice president of public policy. And it was at that point that, my policy portfolio went from essentially trying to represent Chime to Congress and the Hill, but also to ONC and CMS, to trying to represent AMIA to a kaleidoscope of federal agencies and acronyms. You know this well, both of you members of AMIA. The organization is really bound by this concept of informatics, but at the same time, it does have members who look at informatics through a host of different prisms, and that can be through public health or clinical research. It could be biomedical, it could be clinical, and there's even kind of patient health informatics. And so I'm sure in the years since I've left, there's more kinds of different interest groups and affinity groups within AMIA. But from my perspective on the public policy government affairs side, that meant I could dig into not just ONC and CMS policies, but I could dig into FDA policies because we had members very conversant and interested in software as a medical device. I could dig into FCC policies because I think at the time we were one of the very first organizations to say that access to broadband is a social determinant of health. So it was at that point in time that I got a secondary education in what I would call health informatics policy. And we really, we tried our hardest to ensconce that concept, health informatics policy, while I was there as a kind of distinct and separate, but inclusive policy domain alongside health IT policy, which a lot of folks, today recognize, maybe not at a kind of academic level, but certainly within industry, you talk about health IT policy, people kind of go, yeah, I know what we're talking about.
So
that's
I'm sorry.
so that's how I was going to say that's how I got to ONC is from AMIA.
So the world that you've been in, you've gone from being on the advocacy side to being in the government. The government doesn't sell products. The government doesn't actually make things per se, but it does regulate things. It does make the rules. It does set up the framework through which everything works. You got into the government how many years ago now? 7 or 8 years ago at this point?
It's just about 6. So I'm at 5.5 going on 50.
But in the course of that last 5 years, you might have been focused in on, and you still may be focused in on EHR, but there's been just a little tiny new thing that sort of hit the radar in terms of how health IT is being practiced. And, that's what this conversation is going to be about for the rest of the discussion, which is, where is AI from your perspective at the ONC making the most difference? What are you thinking about? What are the issues that we want to go through? And, Leon and I are going to go through that with you and sort of say, get an idea of where is the ONC and how is it impacting things? Will there be an AI meaningful use kind of a thing down the road? What's coming? Before we dive completely there, you've been also, you did a lot of HIMSS work too, if I'm not mistaken. You've been in and out of HIMSS for a number of meetings. So you have the perspective of an advocate, you've got the perspective of someone who's worked with the commercial side of things, and now you're in the government. How have those things sort of shifted in your brain in terms of your own personal focus?
Yeah, that's a great question. Insofar as, I think about this, I do think about this kind of retrospectively. When I look back, I kind of think, okay, how did I get here? And to me, it makes sense as a natural progression. Insofar as I was very lucky both at Chime and at AMIA to represent members who never had a completely antagonistic relationship with the policymakers we were dealing with. I think oftentimes there were discussions and differences in approach, but not in destination. And I think even on the Hill, we crafted a lot of and cultivated a lot of relationships with committee staff who, even if they were antagonistic to maybe the administration, weren't antagonistic to the idea that we need to push forward on interoperability. We need to make these tools better for clinicians. We need to make data more available for patient access and for research. And so I've been very fortunate to be able to come into the government, not necessarily with with an axe to grind, but with the capability, or at least I think I have the capacity to kind of help craft policy that will then um, be more amenable to those who have to implement it, or at least be more cognizant of the folks who are either intended to benefit from the policies or have to implement the policies, which, as you know, are not the same. But I think that has really helped over the course of the last 5 years. I mean, I think, again, um, I I come to the notion of public policy as being an instrument that can be used to do tremendous good at scale. I think that there are even, even when you think about things through that line of thinking, then you think, oh well, more policy means better policy, means we should have more policy. That's not always the case. I just think that to be able to right size the policy and to be able to ensure that the policy is fit for purpose is a really important task. And from my perspective, one of the things that I've really enjoyed about ONC as a culture since I got here, and really a culture since I've engaged with it since 2011, is that it's very open. We get a lot of input from our health IT advisory committees. We used to have two, now we just have one, but we just had our first meeting of this administration last week, of our health IT advisory committee. And this is such an important group of folks who are nominated by different quadrants of Congress, as well as the Government Accountability Office. And these individuals, these are experts from the field who give us windows into what's going on. You mentioned HIMSS. There are a ton of industry activities, industry conferences, and I think this year I was somewhat uh, somewhat aghast that I was working on at least my 11th or 12th HIMSS, if not something higher. And I decided I didn't need to really go back and think about it all that too hard. But certainly the industry engagement that we have is actually really important, because the job of a policymaker on the inside is really to try and find that middle ground, find that compromise that will help um, both sides get, and that will help push forward the policy objective, probably in ways that are not directly amenable, or at least directly preferred by either industry or by providers or by patients, but like, really trying to craft that policy in a way that says, okay, given all the input that we have heard, these are the steps that we need to take from a regulatory perspective, or this is a set of issues that we need to elevate from a priority perspective. And so, I think that the culture here again is just one of openness, and we end up having a lot of meetings with a lot of different interested parties or stakeholders, and those are all kind of, in some ways very directly, in other ways, through public comment periods, and other ways, just kind of more informative. But they always kind of come in at the end of the day to help us think through where's the direction we want to go, big picture, and then what are the policies that we want to take to get there, and then what is the negotiation that has to occur in order for folks to actually implement those policies. Because at the end of the day, we have a pretty solid policy tango that we have with CMS. I think maybe tango isn't the right dance that we've got. I don't know, maybe it's a two-step, but we have a voluntary program. There's not a single EHR in the country that has to certify to this, to our program, but they do it because then their clients will get reimbursed 100 cents on the dollar. And so that's a dance, and it takes a lot of people to figure out how to do it properly.
Well, Jeff, first, delighted to have you with us. Miss working with you from your AMIA days. I've always found you so sensible, pragmatic, and knowledgeable. And I'm glad to have someone like you working in the federal level and shaping federal policy, whatever the dance steps required, right? Whether, probably a waltz is in there somewhere.
It is, yeah, absolutely.
Yeah. And also thank you for making us introspect whether we're a pod or a cast. I'm sure Steve and I will have to have several high-level strategy meetings on this. But, what I want to come back to is that there's something you said in our prep call that really struck as a leverage point. The EHRs are both the wellspring of data for AI, and the mechanism for getting AI outputs into clinical care, right? So it's there the pipe out, and then there's a pipe in, but they can also be the bottleneck. Walk us through what the tension looks like from where you sit at ONC.
Yeah. Yeah. So, I mean, I think I'm glad that that resonates because I think for me, it's really helpful to, help people understand the centrality of the electronic health record, even though it's not necessarily seen, I think, universally as this central point. Um, in terms of, we think about things in a couple of different ways, technical standards and capabilities, behavioral and kind of business practices by the developers who deploy who develop those technical standards and capabilities, and then we've got a broader surround of information blocking. And so to try and kind of frame this for you a little bit, and to bring you into kind of current day ONC, um, we have over the last several years pushed to try and advance a nationwide kind of infrastructure, one that is predicated on FHIR, the HL7 standard, and one that's predicated on APIs. And I think we've had a certain amount of success in this regard, especially as it relates to patient access. I think that the value proposition hasn't quite developed yet on the patient access side, but more specifically on the kind of provider to provider exchange side. I mentioned three things. So technical standards, business and behavioral, and then information blocking. And I would kind of think about, we regulate the technology, we regulate the developer of the technology, and then we exist in this statutory environment that Congress established in the 21st Century Cures Act of 2016. And essentially what this does is it makes information blocking illegal,
Mhm.
just point blank. Okay, well, what does that mean? That means that blocking is essentially defined as a practice that is likely to interfere with access and exchange and use of electronic health information. And there's a caveat there, like the actor who is supposedly engaging in information blocking, if the actor knows or should know, that's when if they're kind of actively getting in the way, that's when they're in violation of this statute. And ONC was charged by Congress to establish various exceptions to this. And a good one to kind of keep in mind is like privacy. If a hospital thinks that somebody is trying to get access or use information that that the hospital doesn't think the person should have access to, then they have an exception, a privacy exception. Well, over the course of the last several months and years, again, we get a lot of input from industry, and the notion is, um, do we need to modify those exceptions? Do we need to modify the definitions? And in a recent regulation that we put out as a proposed rule called HTI 5, Health Data Technology and Interoperability, version 5, we proposed a number of updates to our information blocking kind of regulatory regime that were really meant to prevent exceptions and contracting leverage from becoming kind of de facto interoperability gates, especially in the context of care delivery that increasingly relies on API-driven, automated, and AI-mediated workflows. I'm happy to talk through a couple of those finer points there, but I think what I want to try and convey here is HTI 5 is largely known as a deregulatory rule, and it is. The industry knows that we're proposing to remove a really high percentage of the existing certification program certification criteria, and we're looking to scope down some of the conditions and maintenance of certification requirements, and these are kind of the policies that regulate the developers, not the technology. And then, but we did have a section of HTI 5 very much focused on trying to ensure that the the regime around information blocking wasn't inadvertently inhibiting the proliferation of agentic workflows, and wasn't used as a contractual lever to create kind of discriminatory access.
Yeah. So Jeff, I think that the consequence, or the practical consequence of what you may be reacting to as relevant to AI is that AI solutions developed by EHR companies themselves are much more easily deployable than third-party or in-house solution, right? There's this asymmetry. And the concern is that EHR vendors who control the platform might be creating artificial moats of various kinds, right? Some intentionally, some unintentionally, against third-party AI. The HI5 is the framework. Can you share with us how you think about separating legitimate technical and safety concerns from genuinely anti-competitive behavior?
Yeah, so I mean, I'll go in just one layer deeper on some of the proposals in HTI5 to help tease that out. So, the information blocking regulations, which we kind of affectionately refer to internally as those at 45 CFR 171,
I'm
are
sorry, say that
I can
again.
sense the
yeah,
affection as you say it.
yeah. The affection he has. Actually, I don't have as much affection for them. All my regulations are in 170, so that's where I light up. 171 though is the information blocking section, and the these regulations are essentially are meant to be a playbook for industry, uh, particularly lawyers, to try and discern when was an action legitimate and for safety reasons or for privacy reasons or for a small list of additional reasons, and when was this action um, nefarious, for lack of a better phrase. And I think a couple of things. So one of the things that we've tried to do is, I mentioned that information blocking was essentially defined as a practice that's likely to interfere with access, exchange, and use. One of the things that HTI5 does is it clarifies in regulation that access and use includes automated technologies, including robotic process automation and agentic or autonomous AI systems. So we're basically saying it doesn't matter if it's a human trying to access and exchange and use, or a robotic process automation or agent. Those things should still be able to, should be able to engage with the electronic health information. And so that kind of sets like that clarifies the floor that everybody should be standing on. Now, in terms of trying to walk that balance between legitimate use and information blocking, there's a couple other provisions in there, and they really do try and articulate things that we're seeing in the market, and that is the blocking of write back capabilities for some when it's not being done for others, and there doesn't appear to be any meaningful difference between the some that are getting write back access and the some that aren't. And a lot of the information blocking stuff is very, very legal insofar as you have to have a very particular fact pattern. So it's hard to explain exactly in the abstract, but what we're trying to do is create clarity around those scenarios where an actor, I'll just have to use that blanket phrase, cannot claim an exception because what they're doing is clearly preferencing one party or one mode of access over another, and they have no other categorical reason to be doing that. So, I know that there's going to be there are a ton of nuances in this space, and I will say for your audience and to get me out of this, I would say please send all inquiries to healthit.gov /portal or health IT inquiry portal. Yeah.
So, Jeff, I know that the ONC has put out an RFI relating to AI, and I know that there's going to be folks listening to this podcast who may be interested in responding to it. Can you maybe give us a quick overview of what it's calling for and what guidance you could provide to those who are interested in responding?
Yeah. So absolutely. I think one of the things to kind of think about is that like HHS is always trying to make sure that like our policies and our incentives, and those incentives could be regulatory, they could be grant making, they could be uh, cooperative agreements and other types of those kinds of levers. But we're always trying to make sure that these are kind of aligned, even though it is difficult to ensure alignment across a department as vast as HHS. And so this administration put out an AI request for information really at the same time as or around the same time as the HTI 5 request for public comment on our notice of proposed rulemaking. And really the questions landed in three buckets. It was, where are the research opportunities that HHS needs to be strategic about? What are the regulatory levers, either regulatory levers that need to be strengthened, or what are the regulatory levers that we need to kind of revisit and maybe loosen? And then what are the reimbursement pieces that are hindering the proliferation of AI? And I think this is really one of the first times that HHS has been very specific in thinking about the healthcare sector, or even the health sector broadly. But I think really the RFI did try and focus on our basically trying to help facilitate the proliferation of AI in the health sector in a way that's both responsible and fair. But again, this is coming from the secretary's office. It's intended to focus on what can we do as an entire department to ensure that reimbursement is supportive of the new paradigms that we're seeing in terms of agentic workflows, and how is it that we want to how do we want to promote this in a way that helps relieve burden and create efficiencies, but doesn't actually then end up in a scenario where the doctor no longer gets paid for anything. But we're interested in areas of research. Certainly, there's a lot in terms of trying to create common data platforms and research platforms that could be useful and reused. And then on the regulatory side, I think we are thinking how to align regulations, especially those that are appearing to be out of step. And how do we ensure that the regulations that are there are fit for purpose, especially for, again, a technology that continues to evolve and change after it's deployed. And I think, within the context of software as a medical device, there has been a very long-standing conversation going back several years focused on treating software as a medical device different from a medical device, which of course doesn't change once it's gone through an FDA review process. And once it's given the green light to get marketed, software as a medical device, AI-driven decision support, these kinds of things continue to evolve, and for the most part, very intentionally. And so the question is, can we design a regulatory regime that will help facilitate market access to those tools? And then, I think there is a very interesting regulatory question around the emergence of LLM-based and generative tools that are increasingly being used, not just for note-taking, but for a whole bunch of things emanating from that AI scribe, and offering billing codes, offering orders, and drafting other types of things, kind of getting more integrated into a clinical workflow, and trying to think about how would we go about as a community. One of the things we think about is, like, what are the levers of government, but then what are those levers that are just outside of government, the levers that government will never be able to have, or at least won't have until Congress gives us those levers. But and that necessitates a distributed accountability approach that I think there is a lot of thought going into, and hopefully over the course of the next several weeks and months, start to see some more kind of I guess kind of strategic documents coming out, and then from there, hopefully some concrete policies that are aligned with what we heard from industry.
So, I think you're hitting on something that we've seen both at our work at Harvard and in the virtues of this podcast, which is that this field is moving at a pace that is outstripping regulators and lawyers, for that matter. They have pointed out that everything is moving at like warp speed, and the government is able to move at snail speed, maybe, if we're lucky. And those two are incompatible, and it leaves this gap of how do we move in a way that is both deliberate and actionable, that can help us actually address some of these. And folks are looking for guidance right now, I think is a real challenge. As you bring, you talked about AICDS, and that's one of the areas that I've been focused on in my work at Harvard, which is, do we regulate AICDS? Do we have rules? Do we have to have it certified? Do the AI models have to have some kind of a testing to make sure that these are safe and effective? I mean, all these are questions that are out there, and I don't know if the ONC is the right place or the right body to, regulate this or comment on this or but I'm looking to you as someone who's been in the field from all angles. And I don't know if you can comment on that or not, but it feels like this is folks are looking for what to do next. And the lawyers are telling us we don't have answers yet. We don't have case law. The government's moving on things at a similar pace. So, if you can't say so because of where you happen to be, and I get that, but do you have a thought on that?
I think I'll observe a couple of things. One is that the RFI that I just mentioned did come from ONC, but ONC is I would it's got a regulatory purview, and that's through certification of EHRs. And other health IT, and it's got a regulatory purview on establishing exceptions for information blocking. But I would say where we're looking to make an impact here is more on the coordination side of things, because one of the things that you learn early on once you get to ONC is that we actually can't do all of the things that we want to do. We have to work through our partners at the FDA and through the CDC and through CMS. And if you look at meaningful use, we certify the EHRs, but that's voluntary. CMS is the one that incentivizes and regulates the use of this certified technology and regulates the use. We can make this certified technology be capable of handling all of the US CDI data elements, but we can't make providers share that information. We can't make providers collect that information. We can't make providers send that information to specific places. And so there is a very finite role. But on the coordinating side, I'm quite optimistic, and that the answer to the question on how should we be thinking about this, what should we be thinking about, this is going to be something that I'm hopeful. What ends up coming out of the AI RFI is a sense of strategic direction that helps people understand where they fit in the puzzle. And when you think about the number of interested parties engaged in the task of ensuring that a single patient can benefit from the wonders of this technology, it's a huge cast. It's not just clinicians, it's not just organizations, it's not just industry. It's honestly, there's lawyers, there's academia, there is a galaxy of there's a universe of folks who are involved in trying to ensure that this technology is used to its optimal benefit and that its harms are reduced to its lowest level.
So
I think,
sorry, I was going to just say, so given that what you're describing around this RFI, what we didn't ask you, which is when is it due? What are the parameters around responding?
So actually, I just checked, and the deadline for comment has already passed.
Oh,
however, that just means that the task of actually making something real out of the RFI and then having people kind of weigh in on that is nearer than it would be otherwise.
So there's a synthetic time of this exercise, I would guess then.
Yeah, but I think what comes out of this is going to, I hope what comes out of this is something that is, I hate to say this because it's such a cliche. It'll be a living document. But I do think the intention is that. I think the intention will be that whatever kind of products, whatever kind of resources come out of this exercise, it will help move the community, the universe, the galaxy of different professions and professionals try and understand, okay, we don't have the roadmap exactly, but we're starting to build out a blueprint that can help people, kind of help people understand where their role in building out the scaffolding is.
So Jeff, I just got to get to like a really important question about the HTI-5, which is a redefinition of what a user is that includes automated processes. That's a significant conceptual move. And I just want our audience to understand what that implies, right? So the implication here is if an EHR blocks an authorized AI agent from accessing data, that's information blocking. It's the same as they block the patient or a human clinician from accessing data. How are the EHR's vendors responding to this framing?
You would have to go to their publicly available responses to check to know that. I don't feel comfortable characterizing exactly because I haven't read through them all. But I think, I think everybody, one of the things I really enjoy about healthcare is that generally speaking, everybody has a sense of urgency and caution at the same time. And it depends on who you are, whether, and it also depends on whether you have urgent caution or you're urgently cautious, or you preference urgency over caution. But I think the tug and pull is real, and I can't even say exactly when we might finalize HTI-5, but I will say that some EHRs are kind of looking at this and going, yeah, okay, this makes sense. And I think there's probably some out there that are less enthused about this notion. I will say that this is one of those classic government situations where we tried to make clearer in earlier communications. I think there's an FAQ that we put out a while ago that tried to make this kind of this notion that agents can be people within the context of user and information blocking. But we felt that it was important to do this through a regulatory process, so that we could get notice and comment, so that we could get some comments on it. And I would be out over my skis if I said how exactly we're going to land on this, but it is something to keep your eye on.
We're going to try to get you to answer just a couple of more questions before we start to wrap. But there's one more thing I need to get to about the changes in direction. So right now the paradigm is about getting data out of EHRs, right? But you're asking
Right.
a slightly different question in your work. Is it information blocking to prevent data from being written back in?
Yeah.
And walk us through that tension. I mean, FHIR supports CRUD operations, right? You can update and delete and create, but EHR certification always traditionally required read and search. However, that's just like tradition. And so there's a gap between what's technically possible and what's actually required. How are you thinking about that as a regulator?
Okay, yeah. Now you've jumped back over into 45 CFR Part 170. Now I'm on a little bit firmer ground, and
The
He planned it
inflection
that
is
way.
back in your voice, I can tell.
you can hear. So I think a couple of things. I mean, you're right. The current regulations right now, as they stand, are very much focused on the capability to read and search. But I would also point out that we've got a new set of regulations focused on facilitating prior authorization. And for those wonks out there, it's 45 CFR 170.315 G 31, 32, and 33. Essentially, across those three new certification criteria, which we finalized, I think, in August of 2025, we established for the very first time requirements for Health IT modules that certify to those criteria to be able to support specific subscriptions and specific CDS hooks. And, I think to your question, Leon, I think one of the things that we're excited about is this notion of um, pondering a world where create, update, delete, read, and search are all part of what a modern electronic health record can support. And of course, we know that they can support this already. I mean, like we know that this is supported in various contexts. But I think that there's a whole galaxy of use cases out there, from wearables to updating of kind of writing back for clinical notes. And the Argonauts, I don't know if you're that familiar with the Argonauts. This is a group that was, instrumental in industry group that was instrumental in trying to get that first kind of US core data for interoperability set off the ground, and really kind of helped push FHIR as a core forward. they've been working pretty diligently for a number of months, if not years, on trying to define these broad use cases where you could essentially establish write back capabilities in a consistent way. And this could be again for things like continuous glucose monitors, or it could be for medical device data, or it could be just a common way of helping patients understand when there's been updates to their clinical notes, not just to their lab results. So, I think there's a lot of really interesting work being done in the standards development space. We are not regulating that today, but we're certainly interested in it, and we're certainly
Yeah.
interested in following along where the industry goes.
So Jeff, it's been phenomenal to hear your perspective and such a service to the industry. So thank you for joining us. You're sitting at an intersection of policy, technology, and clinical care in a way that very few people have to and get to. And there's one thing, if there's one thing you want our audience of health system leaders and life sciences executives to understand about where health IT regulation is heading, what is it in 60 seconds?
I want to say the target that we're always aiming for, but I think particularly now it's fit for purpose, and it's
Mm.
also trying to be cognizant of where the future is coming at us most rapidly. These are pretty incredible times to be in a position like this, because we watch the technology advance so incredibly fast in the industry, especially on the consumer side. And what we try to do is we try and look at that and say, okay, where are there connections and technologies and capabilities taking place that we think are good and should be celebrated everywhere? Because right now,
Mhm.
as is often the case with technology and the future, it's now, but it's not evenly distributed. And the same is very true of care and high quality care delivery. And we have a say in it. High quality care delivery is going to be through the use and access and exchange of data. And so we look at this and say, there's really cool stuff going on over here, here, and here through our levers of certification. How can we make sure that that's happening everywhere?
So, Jeff, it was wonderful to have you. Thank you for joining us. Um, where can people follow the ONC's work and engage with these policies and conversations if they want to learn more?
Sure. You can go to healthit.gov. We just rebranded the website to recognize that we're back at ONC, no longer ASTP. So healthit.gov. Of course, that domain actually never changed. But you can find us there, and we put out and we operate in the public good. So we operate out of the public domain.
We will all like and subscribe this particular department of the federal government. I just want to thank Steve and Jeff and our audience for a great conversation today, and hope everyone can join us again next week for another exciting episode of Practical AI in Healthcare.
Thank you for joining us this week on Practical AI in Healthcare. If you're ready to go beyond buzzwords and hype and explore how AI is truly transforming healthcare, stay tuned for more conversations that get us to what works. Until next time, stay practical.